Welcome, everyone. Today we're diving into something that might seem a bit removed from our microtomes and staining racks, but it's actually the bedrock of everything we do. We're talking about patient consent and rights. You might think, I just process the tissue, I don't talk to the patient, but understanding the why behind that specimen on your bench is crucial. If that tissue was taken without proper consent, we've got a major ethical and legal problem before the first block is even embedded. So, grab your coffee, settle in, and let's explore the sacred right of individuals to control their own bodies. Building on that idea of individual control, let's start with a heavy hitter. Back in 1891, the Supreme Court basically said, hey, your body is yours. No right is held more sacred than the right of every individual to the possession and control of their own person. In histotechnology, this means every biopsy, every resection, and every scrap of tissue we handle represents a person who made a choice to let a doctor take it. We aren't just processing samples. We are processing the physical manifestations of a patient's trust and their right to self-determination. It's the bedrock of our legal system, and it should be the bedrock of our professional ethics too. But what exactly does that choice, that consent, really mean? So what is consent? It's not just a signature on a blurry photocopy. It's a voluntary agreement by a person with sufficient mental capacity to make an intelligent choice. Think of it as a legal shield. Without it, touching a patient, even for a life-saving biopsy, could technically be considered battery. In our world, consent is what turns non-consensual touching into therapeutic interaction. It's the difference between a medical procedure and a crime. And for us, it's the green light that says, yes, you can process this tissue. But consent isn't always a one-size-fits-all kind of deal. Following up on what consent actually means, it comes in three main flavors. First, verbal. Sure, doc, take them all. Second, written. The gold standard, providing visible proof of the patient's wishes. And third, implied. This is the silent act. If a patient walks into the lab, rolls up their sleeve, and looks at the phlebotomist, they've implied consent for the blood draw. They didn't have to say a word. However, in histotech, we almost always want that written paper trail. Why? Because he said, she said doesn't hold up well in a deposition when someone realizes they didn't actually want that simple procedure. But even a signature isn't enough if it's not truly informed. Here's where it gets tricky. Consent isn't valid if it isn't informed. A patient needs to know the what, why, and what else. This includes an explanation of the illness, a description of the proposed treatment, the risks, mortality and morbidity, the benefits, and, crucially, the alternatives. If a patient signs a form but doesn't understand that the biopsy might leave a scar, or that there's a non-invasive option, that consent is as thin as a 2-micron section. As techs, we rely on the clinicians to do this heavy lifting, but we need to know what a good consent looks like. And sometimes, even with all this information, the answer is still no. So we've talked about informed consent, but what happens when a patient says no? A competent adult has the absolute right to decline any and all medical interventions, even life-saving ones. It's their body, their choice, and that autonomy trumps our desire to fix things. This can be incredibly frustrating for healthcare providers because we're wired to help. But remember, our job isn't to force health on people. It's to provide the tools for health if they want them. If a patient refuses a biopsy that could catch their cancer early, we have to respect that. It's a tough pill to swallow, but autonomy beats beneficence in the legal arena almost every time. Now, what about those times when consent is presumed? So what if the patient is unconscious and bleeding out? We don't just stand there, waiting for them to wake up and sign a form. This is the emergency exception. The law presumes that a reasonable person would want life-saving treatment if they were able to ask for it. It's called statutory consent. But, and this is a big but, if that patient had already refused the treatment while they were conscious, you can't override that just because they passed out. The no sticks, even when the lights go out. This exception highlights the tension between saving a life and respecting a patient's prior wishes. It's a complex area, and it brings us to a landmark case that really hammered this home. The Dax Coward case is a staple in medical ethics for a reason. He was severely burned in 1973, competent, in excruciating pain, and repeatedly asked to die. His doctors ignored him, treated him anyway, and he survived. He went on to become a lawyer and spent his life arguing that his rights were violated. This case forces us to ask, is a good outcome, like survival, worth violating a person's fundamental right to choose? For Dax, the answer was a resounding no. It's a sobering reminder that our success stories might be someone else's nightmare. But how do we even determine if someone is capable of making such a profound choice? Following the Dax Coward case, we have to ask, how do we know if someone is competent to make a choice? We look at decision-making capacity, or DMC. It's not a yes-no for everything in life. A patient might be able to decide what they want for lunch, but not whether they want a radical mastectomy. DMC requires the ability to understand the condition, reason through the choices, and communicate a consistent decision. If a patient is delirious from a high fever, their no might not be a valid refusal. It's a sliding scale. The bigger the risk, the higher the level of capacity we need to see. So what does all this mean for us, the Histotechs? You might be thinking, I'm just in the lab, I don't do the capacity assessments. True. But our ethical duty is to treat every specimen with the respect it deserves, because of the autonomy it represents. When we lose a specimen or mix up a block, we aren't just making a technical error. We are violating the patient's trust and the right to have their diagnostic journey handled with care. We are the stewards of the patient's physical self once it leaves their body. That's a big responsibility, folks. Don't treat it like just another piece of meat. And this duty is echoed across all healthcare professions. So we just talked about our ethical duty as histotechs to respect the tissue as a representation of the patient. Now let's zoom out a bit. Every major medical organization has a code of ethics that hammers home the importance of consent. The AMA for doctors, the ANA for nurses, and the ADA for dentists all agree. The patient has the right to self-determination. These codes aren't just suggestions. They define the standard of care. If a professional ignores these, they aren't just being old school or paternalistic. They're being unethical and potentially opening themselves up to massive legal liability. In Histotech, we follow similar principles: accuracy, integrity, and respect for the patient. It's about ensuring that the entire healthcare team, from the surgeon to the lab tech, is aligned on these fundamental patient rights. This brings us to a concept we've thankfully moved away from. That concept is the paternalism trap. In the old days, medicine was very paternalistic. The doctor was the father figure who made all the decisions because they knew best. We've moved away from that, thankfully. Social policy no longer accepts the view that a doctor can stay silent about risks just because they think the patient might make the wrong choice and refuse treatment. We've traded doctor knows best for the patient knows what's best for them. It's a shift from control to collaboration. And yes, that means sometimes they'll make choices we disagree with, but respecting that choice is key to patient autonomy. This shift from paternalism to patient-centered care is a huge part of the bigger picture of patient rights. Consent is just one piece of the patient rights pie. The Patient Self-Determination Act of 1990, or PSDA, was a game-changer. It requires healthcare organizations to educate patients about their rights, including the right to accept or refuse treatment, and the right to create advance directives, like living wills. It's not enough to just let patients have rights. We have to make sure they know they have them. It's like the Miranda rights of the hospital. You have the right to remain healthy, or not. It's up to you. This broad understanding of patient rights also includes some very specific protections, like the right to privacy. This is where we really come in as histotechs. Patients have a right to privacy and confidentiality. In the lab, this means HIPAA. Every slide you label, every report you print, and every conversation you have about an interesting case must be protected. A patient's diagnosis is their business, not yours to share at the water cooler or on social media. Even if the tissue is cool or the pathology is rare. That's a person's life you're looking at through the microscope. Keep it professional, keep it private. And speaking of clear communication and patient understanding, another crucial right often overlooked is the right to an interpreter. Imagine being told you need a major surgery, but you don't speak the language. Terrifying, right? Patients have a legal right to a professional interpreter. This isn't just nice to have, it's essential for informed consent. If a patient consents because they just nodded along to words they didn't understand, that consent is void. In the lab, if we're ever involved in patient-facing roles, like fine needle aspirations, we need to ensure that communication is clear and understood. No Google Translate for medical decisions, please. Because without clear communication, how can a patient truly exercise their right to ask questions? After ensuring clear communication with interpreters, we move to another crucial patient right: the right to ask questions. Patients aren't just passive recipients of care. They're active participants, and their questions are a vital part of that engagement. These aren't just annoying interruptions. They're a patient exercising their right to be involved in their care. For us in Histotech, we often get the "why is it taking so long?" question from clinicians. Our right is to provide an accurate answer, and the patient's right is to know that their tissue is being handled correctly. Communication is the cornerstone of safety, and it flows both ways. Next, we'll flip the coin and look at patient responsibilities. So we've talked a lot about patient rights, but it's not all. Take. Patients have responsibilities too. Just like a good relationship, healthcare is a two-way street. Patients need to provide accurate health information, follow treatment plans they've agreed to, and be respectful of others. If a patient lies about their medications and has a complication, that's on them. In Histotech, we rely on accurate clinical history to make a correct diagnosis. If the patient or the clinician doesn't provide that, our job becomes a lot harder. Rights and responsibilities are tethered together, creating a balanced partnership. Now let's dive into a high-stakes environment where these rights and responsibilities often clash: the emergency department. Following our discussion on patient responsibilities, let's consider where the rubber meets the road: refusal in the emergency department. The ED is the front line of refusal. It's fast-paced, high-stress, and decisions have to be made now. This is where the conflict between saving a life, beneficence, and respecting a choice, autonomy, is most intense. Doctors in the ED often err on the side of life because they don't have the luxury of time to consult an ethics committee. But even in the ED, a competent patient's no must be respected. It's a tightrope walk, and the stakes couldn't be higher. This brings us to the nuanced concept of capacity, which isn't always a clear-cut yes or no. Building on the complexities of refusal in the ED, we now explore the sliding scale of capacity. Think of capacity like a security clearance. For a low-risk procedure, like a blood draw, we only need a low level of capacity. But for a high-risk life-altering procedure, like an amputation or a major resection, we need a high level of capacity. The more serious the consequences of the decision, the more sure we have to be that the patient truly understands what they are doing. It's a way to protect patients from making impulsive, life-ending decisions while still respecting their ultimate autonomy. This concept becomes even more critical when we talk about refusing life-sustaining treatment. Moving from the general concept of capacity, we arrive at the ultimate test of autonomy: refusal of life-sustaining treatment. This is the final boss of medical ethics. A patient with 85% full-thickness burns says, "Let me die." They are competent, they understand the prognosis, which is grim, and they are making a choice consistent with their values. Do we honor it? The law says yes. Ethically, it's a struggle, but providing treatment that only prolongs death rather than preserves life can be seen as its own kind of harm. Sometimes, a dignified death is the most compassionate thing we can provide. Next, we'll consider who speaks for the patient when they can't speak for themselves. So we've talked about the ultimate test of autonomy, where a competent patient makes a life or death decision. But what happens when a patient can't speak for themselves? That's where relatives often step in, and it gets messy. If a patient lacks capacity, who gets to decide? Ideally, it's a legal guardian or a designated healthcare proxy. But often, there isn't one, and family members jump in, sometimes with their own agendas. They're supposed to make a substituted judgment, meaning, what would the patient actually want, not what the relative thinks is best. This is a huge source of conflict in hospitals and can really delay things, including the very specimens we're waiting to process in the lab. It's a tough spot, trying to honor a patient's wishes through someone else's filter. Next, we'll look at what happens when patients just decide to leave, regardless of medical advice. Building on the idea of patient refusal, sometimes patients just say, "I'm out of here." This is what we call discharge against medical advice, or DAMA. It's a specific type of refusal where a patient decides to leave before their doctor says they're ready. You see this a lot in the ED or in psych units. It's super risky, leading to higher readmission rates, more complications, and sometimes even death. But here's the kicker. Unless they're a danger to themselves or others and meet strict legal criteria for a hold, we can't chain them to the bed. We have to let them go, usually after they sign a form acknowledging the risks. It's a stark reminder that autonomy trumps beneficence, even when it feels like a bad call. So why do patients make these choices? Let's dig into the why behind refusal. We've seen that patients have the right to refuse, even to their own detriment. But why do they do it? Patients rarely refuse treatment just to be difficult. There are often really deep-seated reasons behind their no. Think about it. Fear, a lack of trust in the system, strong religious beliefs, like Jehovah's Witnesses and blood transfusions, or even just financial worries. Sometimes, it's a simple misunderstanding of the information. One study actually found that insufficient information was the main cause of refusal. If we don't explain things clearly and compassionately, patients get scared and say, "Better communication is truly the best preventative medicine for treatment refusal." But when they do refuse, how do we avoid labeling them? When a patient refuses treatment, they often get slapped with labels like non-compliant or difficult. This is a classic paternalistic hangover from the old days of medicine. We really need to be careful not to let these labels influence how we view or handle their care, especially their specimens. A difficult patient's biopsy is just as critical as a compliant one's. In the lab, we should be completely blind to the patient's personality and laser-focused on their pathology. Our job is to provide the most accurate data possible, regardless of how the patient behaves on the ward. It's about maintaining objectivity and professionalism. Speaking of deep-seated reasons for refusal, let's explore how religious beliefs play into these decisions. Following on from why patients refuse, religion is a seriously powerful driver of medical decisions. The classic example, which you've probably heard, is Jehovah's Witnesses refusing blood transfusions. Even if it means they might die during a necessary surgery, we absolutely must respect that choice if they are competent. In Histotech, we might see this play out in how certain tissues are handled, or if, blood-free, alternatives are used in the surgical suite. It's a profound reminder that health isn't just physical, it's deeply spiritual and cultural too. We have to honor those diverse values. Next, we'll talk about the emotional toll these kinds of refusals can take on healthcare providers. It's tough when patients refuse care, especially when we know it could help them. This can really take a toll on healthcare providers, leading to anxiety and even moral distress. We want to save everyone, right? But we can't always. Doctors and nurses often feel like they're failing when a patient says no. In the lab, we might feel a sense of waste when we see a specimen from a patient who then refuses follow-up treatment. It's important to recognize these feelings, but we can't let them override the patient's rights. Remember, respecting their autonomy is paramount, even when it's hard. And if we don't respect that, well, things can get pretty messy. So, what happens if you ignore a patient's valid refusal and treat them anyway? You're looking at a world of legal hurt, my friends. We're talking battery, medical negligence, and a serious lack of informed consent. Even if the patient survives and is better, you can still be sued. The law doesn't care if you were trying to help. It cares if you violated the patient's right to say no. In histotech, this translates to ensuring that every specimen we process has the proper authorization behind it. Because if it doesn't, we're part of that legal mess. This is why the sliding scale of capacity is so important. Let's apply this sliding scale of capacity to our world in histotechnology. A routine skin punch biopsy? That's low risk, so simple consent is usually fine. But a radical neck dissection with multiple lymph node chains? That's high risk, and it requires complex consent. As the complexity of the surgery and the resulting specimen increases, so does the weight of the consent process. When we see those massive resection specimens on the bench, we should realize the intense, informed consent journey that patient went through to get there. And that journey includes the possibility of informed refusal. Just like consent, refusal must be informed. The patient needs to know exactly what they're giving up. We need to explain, if you don't have this biopsy, we might miss a cancer that's currently treatable but won't be in 6 months. If they still say no after that, then it's an informed refusal. Our job is to make sure that no isn't based on a misunderstanding. We want them to make the best decision for them, even if it's not the one we would choose. And as histotechs, we play a silent but crucial role in this whole process. We are the silent advocates for the patient. By maintaining the integrity of the specimen, ensuring accurate labeling, and following all protocols, we are honoring the patient's consent. They consented to have their tissue analyzed to help their health. If we mess that up, we're violating that consent just as much as a doctor who performs the wrong surgery. Every block we embed is a commitment to the patient's right to an accurate diagnosis. And speaking of commitments, documentation is absolutely key. We just talked about being a silent advocate for the patient, and a huge part of that advocacy comes down to documentation. Because in the legal world, if it isn't written down, it simply didn't happen. A doctor can claim they got consent, but without a signed form, that claim is on shaky ground. In our lab, our documentation is our LIS records, our slide labels, and our logs. If we don't properly document a specimen's arrival or a discrepancy, we're breaking the chain of evidence. Proper documentation is how we prove that we respected the patient's journey from the operating room to the microscope. It's how we uphold their trust and ensure accountability. So let's talk about when things get really fast-paced in the lab. Speaking of fast-paced, do we ever have emergencies in histotech? Absolutely. Think frozen sections. When a patient is on the table and the surgeon is waiting for a result to decide how to proceed, that's our emergency. The consent for the main surgery usually covers the frozen section, but the pressure is on us to be fast and accurate. We are part of that immediate threat decision-making process. Our no or yes on a frozen section has immediate, life-altering consequences for the patient's autonomy. It's a high-stakes moment where our work directly impacts patient care. This brings us to a crucial distinction in medical ethics. So let's recap the big shift in medicine we've been discussing. Paternalism versus autonomy. Paternalism is that old-school mindset where the doctor says, "I'm the expert, I'll decide for you." Autonomy, on the other hand, is the patient saying, "I'm the person, I'll decide for myself with your expert input." Medicine has thankfully moved from the former to the latter. It's a shift from demanding compliance to fostering concordance. We don't want obedient patients. We want informed partners in their own care. In the lab, this means we provide the accurate data that empowers that partnership. We are the fact-checkers in the patient-physician relationship. And sometimes, that partnership involves getting a second opinion. Patients have the right to a second opinion, and in histotech, this often means sending slides out for consultation at another institution. We shouldn't be offended by this at all. It's the patient exercising their right to be sure about their diagnosis and treatment plan. Our job is to facilitate this process. We prepare the slides, package them securely, and ensure they get where they need to go. A second opinion is a key part of informed decision-making, ensuring patients feel confident in their care. This right to seek further information also extends to how tissue is used beyond immediate diagnosis. Sometimes, tissue is taken not just for diagnosis, but for research purposes. This requires a separate level of consent, and it's super important. A patient might say yes to a diagnostic biopsy, but no to having their tissue used in a study. We have to be very careful in the lab to distinguish between clinical tissue and research tissue. Using a patient's tissue for research without their explicit consent is a major ethical violation. Think about the Henrietta Lacks case. It's a stark reminder of why this distinction matters so much. We must always honor the patient's specific wishes regarding their tissue. This delicate balance of rights and responsibilities is like a fragile, yet strong, piece of vellum. Let's shift gears from research ethics to a metaphor that really ties everything together. Think of the patient-provider relationship like a delicate piece of vellum. It seems fragile, but it's incredibly strong if we handle it with the respect it deserves. The information we provide is the ink, and the trust that builds between us is the beautiful wash that makes the picture complete. If we get too paternalistic, if we try to force our will, we bleed outside the lines and ruin that delicate image. But if we stay within the boundaries of respect and autonomy, we create something truly special. A healthcare system that genuinely serves the individual. This isn't just about avoiding lawsuits. It's about building a foundation of trust. It's about recognizing that every interaction, every piece of information, contributes to this intricate and resilient relationship. Next, we look at a specific case where this vellum was tested. Following our vellum metaphor, let's dive into a real-world scenario that truly tests the strength of patient autonomy: the Jehovah's Witness surgery. Imagine a patient facing a life-threatening condition, like a colectomy for toxic dilatation, but they firmly state, "I'm a Jehovah's Witness, no blood." The surgeon knows the risks are incredibly high, but the patient's choice is clear. This isn't about medical preference, it's about deeply held religious beliefs. So the medical team plans for a bloodless surgery, using techniques like cell savers and optimizing hemoglobin beforehand, all to respect that profound choice. In the lab, we might see the downstream effects of this, perhaps in the specific handling of specimens or the unique surgical approaches. This case is a powerful example of autonomy triumphing over what might be considered standard medical practice. It highlights that health isn't just physical, it's spiritual and cultural too. This kind of refusal, while challenging, underscores the absolute right of a competent patient to make their own decisions, even when those decisions seem counterintuitive to medical professionals. Now let's explore another aspect of patient refusal: the right to simply walk away. Building on the idea of patient refusal, let's talk about discharge against medical advice, or DAMA. This is when a patient decides, "I'm out of here," even if their doctor thinks they're not ready. It's pretty common in places like the ED or psychiatry, and it carries real risks: higher readmission rates, complications, even death. But here's the kicker: unless that patient is a clear danger to themselves or others and meets specific legal criteria for a hold, we can't force them to stay. We have to let them go. Usually they sign a form acknowledging the risks, essentially saying, "I know this is a bad idea, but I'm doing it anyway." For us in the lab, a DAMA might mean a specimen gets canceled or a follow-up is lost. It creates a gap in the patient's care that we have to document and respect. It's a stark reminder that patient autonomy extends even to making choices we might strongly disagree with. This often comes down to a breakdown in communication, which brings us to our next point. Following our discussion on DAMA, it's clear that many issues, including patient refusal, often boil down to one thing: communication. We've said it before, but it bears repeating. Clear communication is the best tool we have in the lab, and in healthcare generally. Most refusals and even lawsuits stem from a breakdown in how we talk to each other and to the patient. If a clinician doesn't explain a biopsy clearly, the patient might refuse. If the lab doesn't explain a delay, the clinician gets frustrated. If we all communicate with clarity and compassion, most of these ethical landmines can be avoided. Be a communicator, not just a processor. This isn't just about being polite. It's about ensuring informed decisions are made at every step of the patient's journey. Effective communication helps bridge the gap between medical knowledge and patient understanding. And when it comes to understanding, the law often looks at things through a specific lens, which we'll discuss next. Continuing our theme of clear communication, let's consider how the law often evaluates whether consent was truly informed. It uses something called the reasonable person standard. This means when a court looks at a consent case, they ask, would a reasonable person in the patient's shoes have wanted to know about this specific risk or alternative? If the answer is yes, and the doctor didn't mention it, that's a problem. It's not about what that specific doctor thought was important. It's about what a normal, average person would want to know to make an informed decision. This standard helps keep paternalism in check, ensuring that patients receive the information they need, not just what the provider thinks they need. It emphasizes that the patient's perspective is paramount in the consent process. For us, this means the quality of our work directly impacts the information available for those reasonable decisions. Next, we'll explore how our accuracy in the lab directly informs these crucial patient choices. Our work in the lab directly impacts whether a patient can make truly informed decisions about their health. Think about it. If our results are shaky, the whole informed consent process for the next steps crumbles. A bad slide isn't just a technical hiccup. It's a direct hit to a patient's autonomy. If our stain is off or our section is shattered, the pathologist might give an equivocal diagnosis. That makes it impossible for the patient to make an informed choice about their treatment. We are the foundation of that informed choice. We provide the data that empowers patients to decide their next move. So the quality of our work isn't just about accuracy. It's about respect for the patient's right to know what's happening in their own body. And sometimes, respecting that right means accepting a decision we might not agree with. Following up on how our work enables informed decisions, sometimes those decisions are tough to swallow. It's easy to respect a yes when a patient agrees to treatment, but it's incredibly hard to respect a no when you know it might lead to suffering or a worse outcome. That, however, is the true test of our commitment to patient autonomy. If we only respect choices we deem good, we're not really respecting autonomy at all. We're just rewarding compliance. We have to be okay with patients making choices that, with all our medical knowledge, we might think are wrong. It's their life, their body, their number. And sometimes, the reasons behind that, no, aren't so clear-cut. Building on the idea of tough choices, sometimes it's not even clear if a patient can make that choice. We're talking about the gray areas of capacity. What about the patient who's mostly okay but has moments of confusion? Or the teenager who seems mature but isn't legally an adult? There's no magic wand to determine capacity. It takes a whole team. Doctors, nurses, sometimes even psychiatrists or ethics committees to figure it out. In the lab, we just need to be aware that these struggles are happening behind the scenes for many of the specimens we see. It adds another layer of complexity to the patient's journey, and it underscores the importance of treating every specimen with dignity. Expanding on those gray areas, beyond the legal rights there are the ethical ones. We're talking about the right to be treated with dignity and respect. This applies to the patient, of course, but also to their tissue. When we handle a specimen, we should do it with the same care we'd want for our own family. No tossing containers, no sloppy grossing. Every step should reflect our respect for the person who provided that tissue. Dignity doesn't end when the patient leaves the room. It continues right there in the lab. This ethical foundation is also reinforced by institutional responsibilities, which brings us to our next point. Connecting to that idea of institutional responsibility, the Patient Self-Determination Act, or PSDA, isn't just for doctors. It's for the entire healthcare institution. Hospitals must have written policies. They must document whether a patient has an advance directive. And they absolutely cannot condition care on whether someone has one. It's all about creating a culture of respect for autonomy. As part of that institution, we in the lab are bound by these same principles. We are part of the culture of consent. And sometimes, that culture means facing very difficult decisions, like when an elderly patient refuses a life-saving procedure. Here's a case that really tests our commitment to autonomy. An 85-year-old man, recently widowed, with gangrenous appendicitis. He's competent, but he simply says, "No. I don't see the point." This isn't about depression that voids capacity. It's about a man who's just done. We've talked about the PSDA and how institutions must respect patient rights, and this case brings that right to a very personal level. We can't force life-saving surgery on him. Instead, our role shifts to providing comfort care and managing his pain, respecting his choice to let nature take its course. It's a powerful reminder that health isn't always a patient's top priority, and sometimes a dignified end is what they truly seek. Next, we'll try to find some humor in all this heavy stuff. We've covered a lot of heavy ethical ground today, and it's easy to feel overwhelmed. But remember this: the patient is always right, even when they're wrong about their own health. This isn't about being a pushover. It's about respecting their autonomy, which we just saw in our last case study. Our job in the lab is to be the steady hand, providing the accurate data that makes the whole ethical machine work. We might not be the ones getting consent, but we are the ones making it count. And hey, at least the tissue doesn't talk back to us, right? Unless you've had too much xylene exposure, of course. Now, let's pull all these threads together. So, let's bring it all home and calibrate our ethical compass. We've learned that autonomy is king, and consent must always be informed. Remember, refusal is a fundamental right, even when it's a difficult one to accept. Our work in the lab, from grossing to staining, is the absolute foundation of the patient's next informed choice. Keep your ethical compass pointed toward the patient. Treat every specimen with respect, maintain confidentiality, and never forget there's a person behind every slide. You aren't just techs, you are vital players in the ethical delivery of healthcare. Now, what's on your mind? Alright, we've covered a lot of ground today, from the sacred right of self-determination to the nitty-gritty of informed refusal. Now it's your turn to weigh in. What questions are bubbling up for you after all this talk about patient autonomy and our role in it? Have you ever encountered a situation where a patient's refusal made you scratch your head, or perhaps even frustrated you? How do you envision HIPAA impacting your daily work in the lab, especially with all the digital advancements? Let's open up the floor for a good old-fashioned Q&A. Remember, there are no silly questions when it comes to ethics, only those we haven't asked yet. Your insights and experiences are incredibly valuable here, so don't be shy. And with that, let's dive into your thoughts before we wrap things up. As we look ahead, it's clear that the landscape of histotechnology is constantly evolving, with digital pathology, AI, and molecular testing changing how we work. But here's the thing: while the tools and techniques will undoubtedly transform, the core ethical principles we've discussed today will remain steadfast. The patient's sacred right to control their own body, their autonomy, will always be the bedrock of ethical healthcare. So, as you embark on your careers, strive to be more than just technicians who process tissue. Be the kind of histotech who truly honors patients, understanding that every specimen represents a person's trust and their journey. Thank you for your engagement and attention today. Go forth, embed with integrity, and remember the human element in every slide you prepare. Now, if this discussion has piqued your interest and you're eager to delve deeper, I've put together a few resources for further exploration. The Dax Coward case, for instance, is a landmark in medical ethics and a must-read for anyone grappling with patient autonomy. You'll also find the codes of ethics from organizations like the AMA and ANA, incredibly insightful for understanding the professional standards of care. And of course, always stay current with your professional journals. Ethics, much like histotechnology itself, is a dynamic and evolving field. So, stay curious, stay informed, and most importantly, stay ethical. Thanks again for joining me today.